Welcome, dear friends. I'm Dr. Manjunath. I'm a pediatrician and allergy specialist based in Bangalore. In my series of videos regarding allergies and asthma, today I'm planning to talk about atopic dermatitis. It's as common as 20 to 30% of all the problems what we get to see on outpatient basis. And as an adult, almost 5% of the entire population is affected with atopic dermatitis. Before we go to the treatment of atopic dermatitis, let's have a small understanding of what this disease basically is. This is an immune dysregulation between Th1 and Th2 pathway, with the resultant release of so many cytokines, which includes the interleukin 4, 13, 2, interleukin 8, 10, 17, 22, tumor necrosis factor, and interleukin gamma. Th2 inflammation and the barrier breakdown result in reduced filaggrin and the claudin 1 expression. So this is the cornerstone in the pathology of atopic dermatitis. See, for us to make a diagnosis of atopic dermatitis, we have major and minor criteria. Among the major criteria, what we have is pruritus, typical morphology and distribution, facial and extensor eruptions, and chronic or chronically relapsing atopic dermatitis, personal or a family history of atopy, that is either asthma, allergic rhinitis, and atopic dermatitis. There are many minor criteria like xerosis, ichthyosis, elevated serum Ig. Let's not go more into that. We'll stick to the more common ones. And we'll go straight to the treatment. And here we'll discuss the non-pharmacological and the pharmacological treatment and what is to be done and what's not to be done. In the next segment, we'll deal with two things. One is non-pharmacological and second, the pharmacological treatment for atopic dermatitis. So to start with, we'll start with simple things, and that is the non-pharmacological. Among that, the most important thing is the bath. So we should consider the limited use of the non-soap cleansers that are neutral to low in pH. We must understand one thing: the pH of the skin is anywhere between 4 to 5.5. What that means is we should use any soap which is low in pH, which is hypoallergenic, non-fragrance, and preferable one is a syndet or a synthetic detergent. Gentle and the rapid cleansing of the skin at a temperature of 27 to 30 degrees centigrade is preferred. What's not recommended in bathing is harsh mineral oil soaps, alkaline soaps. Harsh scrubbing and long duration bathing is also not recommended. And coming to another important treatment, and that is the bleach bath. Why bleach baths become more important? See, along with the immune dysregulation and the defective skin, the most common problem what a child encounters is the infection, and most commonly the staphylococcal infection. So with the usage of antiseptics, we can control that, but there is always that problem of resistance. So more and more duration you use, there's always the risk of resistance and these medicines not working. But it's 0.005% of sodium hypochlorite was better in controlling, or rather reducing, the usage of topical corticosteroids and the antibiotic usage among the children with atopic dermatitis. Though it did not reduce how the disease progresses, but at least it was helpful in reducing the amount of topical corticosteroids, and antibiotic usage. And another important thing is the salt water baths. This salt water bath helps in removal of dead keratin and crust in ichthyotic skin. Clothing. Smooth clothing, which is lightweight, comfortable, and cotton is the recommended one. Wool should generally be avoided among these children. Too occlusive clothing, including the heat sensation, should be avoided. Among the emollient therapy, which is again a non-pharmacological treatment, we must understand that there are two types of emollients or the moisturizers. These are the humectant ones and the occludent ones. The humectant ones are the ones which promote the stratum corneum hydration, such as the urea and glycerol, whereas the occludent ones, they reduce the evaporation, such as the petroleum jelly. They remain the mainstay of the treatment for mild cases. At least twice daily application immediately after bath is recommended. The use of pure oil products such as coconut oil that will dry out the skin and increase the transepidermal water loss and therefore not recommended. And urea products should be avoided in very young children with a potential risk of renal toxicity. Another important thing we must keep in our mind is sole use of emollients without the sufficient use of anti-inflammatory therapy involves a considerable risk of disseminated bacterial and viral infections in atopic dermatitis. And now we'll go ahead with the pharmacological treatment of atopic dermatitis, among which what we have are the topical glucocorticosteroids and topical calcineurin inhibitors. There are systemic medicines which we are not going to deal today. We're going to deal only with these two simple ones. Whenever we have to use a topical glucocorticosteroid, we must use sufficient strength, sufficient dosage, and correct application. First line anti-inflammatory treatment applied on the inflamed skin and according to the needs of the child, whether it is pruritus, sleeplessness, or the new flare. We must consider a few other things while using the glucocorticosteroids. We must consider potency, galenic formation, patient age, body area to which the medicine is to be applied. All these have to be considered before we even use the topical glucocorticosteroid. They are categorized into 7 groups according to the potency. Starting from super high potency to the lowest potency, we have all the group of medicines in the topical corticosteroids. 2 applications per day till the itch subsides in acute flare-up is to be used. With mild disease activity, a small amount of topical corticosteroid twice or thrice weekly application is enough. See, to summarize, whenever any child comes to us with an acute flare-up, has itching, is crying a lot, doesn't sleep at night with itchiness, at that time we give topical corticosteroid 2 times a day for about a week or 10 days or till the itch and other symptoms subside. Once the symptoms subside, we must reduce the dosage of topical corticosteroids by applying 2 or 3 times per week. This is a maintenance dosage. Such amount of topical steroids, even if they are very potent, are less likely to cause any local or systemic adverse effects. Whenever we are applying it on the face or the eyelids, we need to use the very mild form of topical corticosteroid. And unlike adults, whenever we are using steroids in children, we must use the low potency steroid in comparison to adults. And with the usage of topical corticosteroids, we must also consider a few other things, and that is the fear of side effects or the corticophobia has to be addressed among the parents, which is very common and should be recognized and adequately addressed to improve the adherence and avoid undertreatment. See, it so happens that many a times we write steroids and we tell the parents that, look, these are the steroidal creams, you need to apply it for 2 times a day till the itch subsides, and then on reduce the dosage. With the fear of steroid, many parents don't even consider buying the steroid, and the children are left to scratch. That's not a good scene to see. So with this video, I want to appeal every parent whose child is suffering from atopic dermatitis. Do not reconsider whenever a doctor is writing a topical corticosteroid. It's a very mild thing and the problems are very much limited. So you need to consider whenever a doctor prescribes, please do use it. It is going to be of much better use than the disease by itself. And with this dosage, we don't see the ocular complications in topical steroids. And the next group of drugs, what we have are the topical calcineurin inhibitors, among which we have the tacrolimus ointment at 0.03 and 0.1% and pimecrolimus 1% cream, which are licensed to use in atopic dermatitis. Their efficacy is well established in both short-term and long-term usage. But the data is less available for children under 2 years of age. Initial treatment with topical corticosteroids for acute phase followed by calcineurin inhibitors for maintenance should be considered. So, how do I translate this for a common person? Whenever any child presents to us with a acute flare-up, always consider using a steroid. Once the disease decreases in its intensity, at that time consider using the calcineurin inhibitors like the tacrolimus or pimecrolimus at adequate dosage. Twice daily application till the episodes subside, followed by twice weekly application to prevent relapses is effective in moderate to severe atopic dermatitis, and it also becomes very budget friendly. See, as I said, the steroids are much cheaper creams than calcineurin inhibitors. Whenever we are using for a very large body surface area, using a topical calcineurin inhibitor becomes very, very expensive. For that reason, we need to be very careful, taking into consideration of the parental budget allocations. We must prescribe these medicines. Though they are very good, sometimes budget may be of a concern. And long-term effective treatment of patients with atopic dermatitis may have beneficial effect also on the respiratory symptoms and the serum Ig. There are many reports to suggest that the atopic dermatitis is not the only target for this topical calcineurin inhibitor. Even the respiratory symptoms come down with that. This is a very bold statement and a very important statement to be made for calcineurin inhibitors. Compared to the 0.03% of the tacrolimus, 0.1% does a much better job in reducing the symptoms. But there is always that phobia of increasing the dosage, and we must address that. The most frequently observed side effect with the calcineurin inhibitor is a transient warmth, tingling sensation, or a burning sensation at the application site during the first few days of application. And the topical calcineurin inhibitors do not induce skin atrophy. But this can be a problem if you are using a very high potent steroid for a very long term. But that problem doesn't exist with calcineurin inhibitor. And we must also address very important concern when we are talking about the calcineurin inhibitor, and that there is no increased risk of lymphoma or increased carcinogenicity to other organs. But that can be of concern for many pediatricians, since we are considering tacrolimus or pimecrolimus. Just the name itself is enough to scare many of the pediatricians. But please understand and remember that. But that there are hundreds of studies which have been done. The number of lymphomas or other carcinomas are not considerably increased in children with the usage of calcineurin inhibitors in general population to that of the general population. So what that translate it as is, it's a very safe medicine to use. And another important drug which is yet to be released in India is the topical selective phosphodiesterase 4 inhibitor, or the crisaborole, which has been recently approved for the treatment of mild to moderate atopic dermatitis in children older than 2 years. This is a very promising drug, yet to be widely available and available in India. So we'll wait for days to come. And what's not recommended are the oral antihistaminics and topical antihistamines. 5% doxepin, though useful, is not licensed because there is no enough evidence for the usage of topical antihistaminic. And for that reason, it is not used any longer. And another complication what we might notice is a contact dermatitis with the topical antihistaminic, and it is not recommended at all. And we did discuss about the pathology of the atopic dermatitis, and we discussed that is the dysregulation of the Th1 and Th2 pathway, and histamine was not the most important chemical which got released during that time. And for that reason, antihistaminics barely have any effect in atopic dermatitis. I've seen many prescriptions coming out with antihistaminic, but it is of not much of use in atopic dermatitis. Another important thing what we need to consider is the allergen avoidance and the prevention of triggers. Among that, we have the food allergens and the aeroallergens. Among the food allergens, these are well documented, and approximately 1/3 of children with moderate to severe atopic dermatitis tend to have this food allergy. Cow's milk, hen's egg, peanut, soya, nuts, and fish are the most common products to have food allergy. In older children, adolescents, and adults, pollen-associated food allergy should also be considered into account, which is also called as oral allergy syndrome, which can sometimes cause anaphylaxis. So that has to be kept in mind when we are dealing with food allergy. The most important thing about this food allergy is it's a very difficult thing to diagnose and to prove it. What happens is many doctors would have suggested the blanket ban of many food products, which results in more malnourishment of the child than helping the child. A Cochrane systemic review based on the 9 randomized control trials concluded that eliminating egg from the diet in those children who had positive specific IgE to eggs proved beneficial. So taking away a food from the diet is highly selective. Do not do blanket ban on many products. It's going to be more harm than any good for the child. Aeroallergens like pollens and house dust mite should be avoided in allergy sensitive individuals, which is to be proved on skin testing. Tobacco smoke avoidance, traffic exhaust, volatile organic compound exposure reduction helps in preventing the flare-ups. So in conclusion to this video, I have touched upon the simple and the most basic things, what is to be done and what's not to be done. There are many things which we will deal at a later date. Stay tuned for the next coming episodes. Thanks for staying this long. Share this video and ask any doubts if you want to. I'll be more than happy to guide you on this regard. Bye-bye for now.